A lot of therapists disqualify themselves from even sitting to become a certified hand therapist because they think the exam is too hard or too overwhelming to study for. Well, I'm going to break it down. I want to simplify it for you so that you can see what is possible for you if becoming a certified hand therapist is one of your goals. My name is Huang. I'm an occupational therapist and certified hand therapist, and I always knew I wanted to become a certified hand therapist. I wanted to give myself a shot, but I always heard the same stories that you're hearing still to this day after 25 years, which is the exam is too hard or it's overwhelming. So let's break it down and keep it really simple. I'm actually hosting a free masterclass December 13th, so I'm going to include the link for you. If you're interested, click the link and join. But one of the ways that I work with my staff and my students is just to simplify it so that it's not so overwhelming. So when you think about how overwhelming it is, it's because you're thinking so far into the future. Like, oh my God, I need to learn everything. But if we can break it down and simplify it, you'll just see how capable you are. So I'm going to use an example this week on a finger fracture, right? On a finger fracture because it's top of mind. I was just working with this patient this week, and this case came into me fresh. So the story is this patient was breaking up a fight with her two dogs. So don't just watch what I'm writing, but watch how I'm breaking it down, right? I'm gonna give you a clue. Activity analysis 101. So imagine she's breaking up the fight between her dogs, and the dog bites her, right? And bites her right on her finger. So she sustained a fracture on the small finger, right? So now we have a diagnosis of a fracture. And one of the most important things that you want to know in terms of fracture is where is it located, right? And so a lot of times when people say it's a PIP fracture, then is it your proximal phalanx that's fractured or your middle phalanx that's fractured? So what that does is that starts to help you to think anatomy. It always comes down to anatomy to help you essentially break down what you're supposed to do. I think what happens with most therapists, and you can correct me if I'm wrong, leave me a comment below, but this happens every single time I work with my own staff members in my therapy clinic and also with students. They automatically jump to, what do I need to do? What's my treatment? What's the protocol? But what I want to encourage you to do is essentially to slow it down just a minute, right? I know that the clinic that you work in might be fast-paced, and I know that when the case comes to you, you might not know what it is. And so now you're on your feet trying to figure it out. So in your mind, it's almost like your nervous system is on fire. You're like, I gotta run. But my job here is to kind of slow, I'm gonna rein you back in. I'm gonna slow you down. I can talk slowly if you like and softer if you like, but that's not my methodology. But when we're studying, or when you have an opportunity to think through your cases, this allows you to study better, faster, easier. Essentially, at the end of the day, make it so when you go into the clinic, it becomes easier over a period of time, right? And so your critical thinking portion is slow right now because this is the opportunity as we're learning to slow it down so we can speed up when we're actually in the thick of it, right? So if we see diagnosis of a fracture, this is a bone problem, right? This is a bone problem. And I have several frameworks that I have built out over the years of teaching that help you to critically think through and make it so much easier. When you think about studying in terms of anatomy, I need you to break away from how you were taught in the university system, right? In the university system, they went into so much detail about the bone, the lines, the bumps and grooves and stuff like that. And yes, that was important, but you learned that you've got to let that shit go, right? We need to learn applied anatomy. So when I say applied anatomy, we have to think about what the structure or what the anatomy does for us. So when we're talking about bones, we're talking about structure. So if our bones are broken, then we don't have structure. So then our muscles and tendons can't move the way they're supposed to move. And our ligaments will start to get really, really tight in certain places. Right? So I'm going to draw out. I keep my anatomy drawing very simple. If you've never seen my style, I keep it really simple because we're not artists. I'm not here trying to draw out a real looking hand so you can draw out a real looking hand. I want to teach you so you understand it, so then we can move on to the next phase, right? Because when you do it from a simplistic foundation, you can then add on to the details, right? So imagine we build stick house and then we can start to add on to the details. When we talk about the hand, you're overwhelmed because you're like, oh my God, I need to understand all the tendons. No, just let's simplify it, and then we can add on to it over a period of time to make the studying so much easier that when you start to read, you're going to actually understand what you're reading. People start to read first. They don't even understand the anatomy. Their clinical testing is all over the place because they've just like copied stuff that they've seen other therapists do, or they're just watching snippets of short form content and trying to piece it all together. So I want you to kind of think from a foundational level how to think through it. So this is P3. Let me go P1, P2, and P3. So proximal phalanx, middle phalanx, and distal phalanx. Now you might have already known that in the clinical world, a lot of doctors will shorthand it and write P1, P2, and P3. So we think about a PIP fracture, right? A PIP fracture, she could be fractured here or she could be fractured here, right? Because this right here, my friend, is the PIP, okay? This is a PIP joint, right? So anything that crosses the PIP joint now is a problem. So we have collateral ligaments. We have collateral ligaments on the side of our PIPs. The interesting thing about collateral ligaments of the PIP is that it's always taut or tight, right? Always taut or tight in flexion and in extension. So because it's always tight in flexion or extension, PIP joints tend to get stuck. So majority of people who work in hand or want to work in hand, you're hearing snippets of this and you sort of understand that PIP joints get stuck all the time. And you're already thinking like, oh my God, what do I need to do? How do I make the, how do I push that finger down so the patient can make a fist, right? But we step back, we have to understand why it gets stiff so much. The reason why it gets stiff all the time, no matter if you have a DIP fracture, an MP fracture, whether you have a distal radius, like anything that happens to the hand, the PIP is at risk for getting stuck. And one of the reasons is because of the collateral ligaments, right? One of the reasons why the PIP always gets stuck is because of the collateral ligaments. Now, it can get stuck straight or it can get stuck in a bent, this is straight. It can get stuck straight or it can get stuck in a bent position. It tends to get stuck in a bent position because of the natural attitude of our hands, right? The natural attitude of our hands is, you can do this as well, right? So support your elbow, relax your wrist down, right? Relax your wrist down into wrist flexion. Your MPs automatically go into slight extension. And then the PIPs are slightly flexed, right? Then you can passively put yourself into wrist extension, and then your MPs go into flexion and your PIPs go into flexion as well. But they're always kind of a little bit in flexion, right? This is why PIPs tend to get stuck, okay? So if you understand a certain amount from anatomy, then do you see what I just did here? I just layered on a little bit of information at a time for you, but in a way that we can use that information to apply. When you start studying to become a certified hand therapist, and this is why I love the idea of every therapist thinking to study to become a certified hand therapist, if you want to delve into the world of hand therapy, it's because you start to understand so much of what you do so that you can explain to your patients why they have the problem that they have and what we can do to fix it, right? So the collateral ligaments get really stuck. Kind of moving. Let me backtrack a little bit. So we have a fracture. So remember when I said about bones that there's we don't have enough structure, right? So if the bone is fractured and we don't have enough structure, then we have to fix it, okay? So we have a fracture, then we have to start to think, is it stable or unstable? Oh, hold on, let me do it like this. So we have a fracture. Do we have it, is it stable or is it unstable, right? The reason why it's so important to really think about this is because you as the therapist, you as the certified hand therapist, you as the expert, right? You have to think about where this person stands. When you get a patient who comes in, you have to understand why they had what they had. Someone who is unstable needs surgery. So now you have to think about surgeries and what type of surgeries they're having, right? It's okay, we're not gonna, I can't lecture on a YouTube video, all that. This is all inside the exam prep program in detail, right? So we have to think about surgeries. What kind of surgeries? It leads us down a path, but we also have to think about if it's stable, right? Then what do we need to do from a therapy standpoint? If it's stable, they go straight to therapy, right? They go straight to therapy. If it's unstable, they have surgery and then they go to therapy, right? So let's say, for example, if your patient comes in and they already had surgery, you already know they had a fracture that was unstable and that's why they had to have surgery. And then you understand about the surgery and then you understand about the, right? My patient was somewhat stable. So she was right in between. So she was on the border of being like 50-50. Well, what do you want to do, right? 50-50. Well, do I do surgery? Do I not do surgery? So this is where it can become very collaborative when you are working with a hand surgeon who trusts you. So he was like, I don't know if this girl can like really do the surgery. And I've worked with him before on patients that have been like 50-50. And we have to think about the consequences of what surgery means for that finger and what it means if they don't have surgery. So he opted to send that patient to me and was like, this person is 50-50. Like she could have surgery, but we can try to avoid surgery. And we just had a really successful case together. And so he was like, well, based on how she was presenting, blah, 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 I think we can avoid it. Let's go. So she came in, I think 1 week post-injury. Here's another tidbit. You always want to think of date of injury and date of surgery, right? So she came in 1 week from the fracture, and then what we did was we made her a circumferential splint. So instead of casting her, or I mean, you could cast her, right? There's options, right? There's actually, let's talk about it real quick. There's options. She could stay in the aluminum splint that she came in with that, funny enough, she created herself watching some videos. I think she watched one of my videos on my clinic side because I make videos on the clinic side as well. She made some videos. I made herself an aluminum splint and the doctor was like, yeah, that's pretty good. So he was like, well, go to Huang and she'll like show you what to do. So what we did was we removed that aluminum splint and we made a circumferential splint that went all the way around, because based on where she was fractured, she actually didn't need to include the MP, and initially she did. So I was like, kudos to you. Like, you know more than some of these urgent care centers. They would have wrapped the whole fucking hand out. So anyway, I was like, we don't need to include the MP, the big knuckle, because this is where you're broken. So you see how, because we understand anatomy and the nature of the tissue and the nature of the injury, we know what to do, and then we know how to explain this to our patients. So we made her circumferential splint, showed her a few exercises, and she needs to stay in that splint for a few weeks. And we check it. So let me see, is she 2 weeks? I think she's 3 weeks right now. We redid x-rays because we want, at 2 weeks, we want to actually start, like 3 weeks, we want to start moving it a little bit, not passive, but active. So we want to see that there's some callus formation on the x-ray to say like there's enough stability, because we want to start moving it, because the PIP gets stuck. So we have it splinted straight so we don't get that flexion contracture, but then we also need to work on some flexion. So yeah, so that's where we're at with her. Brand spanking new, and it's really exciting to see how well, you know, she's doing right now. And if you want to ask, like, does she really need a ton of therapy right now? For her finger, not necessarily, but she's actually coming in a lot just because I'm fixing everything else about her body. So yeah, I'm doing all these other things that she actually has going on. So I've been able, because I'm working on like shoulders and neck and all this other stuff, I've been able to just monitor that finger a little bit more than if, let's say, somebody who wasn't coming in as often. That's where we're started. And if you follow my social media channels, hopefully I'll be able to share some of her progress. She just had her x-rays done, so hopefully when I reach out to the doctor, and we just need to make sure we look at it and look for some callus formation. And then once we see some callus formation, we can say like, okay, let's do a little bit more active range of motion, get that finger moving so it doesn't get stiff, right? Studying to become a certified hand therapist starts with being open-minded to learning in a different way, I think. And I think that that will also make it easier for you. I didn't do it that way, unfortunately, because I didn't have anyone help me do it that way. I studied the grind like a beast because I didn't have any resources back in the day. Right? This is like 20 years ago. We didn't have YouTube videos as much as we have it now, and there was really no mentorship, and there was really no one who could spend a lot of time explaining to you and breaking it down. So I had to just kill myself studying. I think that there's a lot of resources now for you that you don't have to do it that way. And if you're struggling to understand the anatomy, apply it, and just make that easier for you, come join my masterclass I'm hosting December 13th. Now, if you're seeing this after December 13th, click the link on my website. I always have resources for you to look at and to consider that can help you understand anatomy so much easier. Don't rule yourself out just because you start looking at rehab of the hand and they're speaking jargon at you. They're speaking academic words, and they're trying to, one person is always wanting to, talk so like hoity-toity and professional, but it makes it so hard for everyone else to understand. But it can be really simple, and I don't want people to think that they can't specialize in hand therapy or they can't even help a patient because they're not a certified hand therapist. There's so many patients that I see that need therapy from all over, and we just need some more OTs that really understand anatomy and how to apply it so that we can treat patients who come in this way, okay? If you like this video, hit the like button, subscribe, and of course my link to work with me are below. So I'll see you on the inside.